My pleasure to introduce our next speaker, Dr. Sukhkamal Campbell. Dr. Campbell is from Huntsville, Alabama, did her residency at the University of Alabama, Birmingham, before going to Houston, Baylor Medical College, and MD Anderson Cancer Center for her fellowship in reproductive endocrinology and infertility. Her fellowship thesis project was focused in fertility preservation for underserved populations in the community setting. She returned to UAB in a faculty position in the Division of REI in 2020 and became the Director of Fertility Preservation Services, Oncofertility, and has worked with her team to grow and develop this program for easy and rapid referral for oncology patients for fertility consultation. Her upcoming goals include starting an ovarian tissue cryopreservation program at UAB in order to provide comprehensive fertility preservation options to all patients in the region. Please welcome Dr. Campbell. Thank you.
Okay, thank you for having me today. I'll be talking on oncofertility in women with hereditary cancer syndromes. Our objectives will be to better understand fertility preservation options that are available and the process involved, to understand the timeline necessary to complete fertility preservation either through oocyte or embryo cryopreservation prior to therapy initiation, and introduce technology that's available through ART and the use of IVF and pre-implantation genetic testing for monogenic disorders. So as we know, hereditary cancer syndromes include cancers that run in families with familial cancer susceptibility. It's a heterogeneous group of genetic disorders showing an increased risk of cancer development during one's early lifespan. 5 to 10% of all cancers will go into this category, with higher prevalence in younger women. And it includes up to 50 identified cancer syndromes with mostly autosomal dominant penetrance, although it is variable. And these syndromes can be suspected in patients who have a diagnosis at an unusually young age, bilateral development, an impaired organ, or when there are 2 or more first-degree relatives diagnosed with the same cancer. This graph just shows some examples of hereditary cancer syndromes, and as you can see, some of them have impact on fertility, including hereditary breast and ovarian cancer, as well as Lynch syndrome, which will have treatments that may affect a patient's long-term fertility and family-building goals. So screening is necessary for high-risk individuals. It allows for implementation of individualized screening schedules and lifestyle changes, as well as cascade testing. And with screening, there are some specific requirements, including in-depth genetic counseling, psychological support, and a multidisciplinary clinical environment. Some concerns that may arise for parenthood with hereditary cancer syndrome. As mentioned before, many of these syndromes have an autosomal dominant inheritance pattern, which would affect the child in many circumstances, and that's where PGTM may come into play. There may be fear of offspring facing diagnoses followed by multiple recurrences from childhood into adulthood, and that may come with some mental and physical strain along with that diagnosis. It's important to discuss genetic predisposition as well as the impact on family planning with both the patient and their partner, if there's one, because this topic may be challenging and burdensome. So there are scant guidelines and data available when looking at fertility preservation in women with hereditary cancer syndromes. In general, women are encouraged to complete childbearing before planning a risk-reducing surgery. ASRM suggests embryo or oocyte cryopreservation prior to that risk-reducing surgery, and the time frame from diagnosis to treatment may allow for a single cycle or multiple oocyte retrievals. Affected women should receive the same standard of therapy for fertility preservation as non-carriers, so they should be offered all options, and there's a recommendation informing carriers of pre-implantation genetic testing as an option. So the different committees, there's the American Society of Clinical Oncology, ASRM, the European Society of Human Reproduction and Embryology, and the European Society of Medical Oncology. They all share similar recommendations on fertility preservation counseling with a reproductive specialist early after diagnosis for patients that are interested or ambivalent about their fertility preservation in the future or their family building goals. The validated options are below, so oocyte and embryo cryopreservation, which our prior speaker mentioned, involve a 2-week period of controlled ovarian hyperstimulation. Other options include ovarian tissue cryopreservation, ovarian suppression with a GnRH agonist therapy, or ovarian transposition with gonadal shielding from pelvic radiation. So first we'll go through controlled ovarian hyperstimulation. This involves about 10 to 14 days of daily injections of gonadotropins, FSH and FSH-LH combination, subcutaneous injections, and the goal is to include multifollicular recruitment. There will be ultrasound monitoring to monitor the follicular growth, and once the average size of the follicles is 18 to 20 millimeters, when they're considered to be maturing, we will proceed with the trigger shot, which will then lead to the egg retrieval, which is a transvaginal cyst puncture. In general, we do these procedures vaginally. At times, we've done them abdominally if the ovaries are outside of the cul-de-sac, and it's easier to access them in the abdominal cavity. But in general, they're done transvaginally with ultrasound guidance. The follicles are aspirated. Embryology will be in the room to look through the follicular fluid and search for the eggs that are present. And if time allows, then a patient may be able to have more than one attempt of oocyte cryopreservation prior to their treatment timeline. On the left, you'll see oocytes from their immature to mature phase, and on the right, you'll see embryos that are watched for a week after the egg retrieval as they develop and continue on to form the blastocyst, which will be biopsied for genetic testing between usually day 5 and day 7. So what's the difference between cryopreserving oocytes and embryos? With oocytes, there's no requirement for a sperm source, so it allows for greater reproductive autonomy for some patients who may be unpartnered or who may not want to use donor sperm. With embryos, we have the ability to do pre-implantation genetic testing for both aneuploidy and monogenic diseases. It may be suspect to ethical or moral or religious concerns related to disposition of embryos if the patient passes away or if the patient doesn't have clear plans on how to use the embryos in the future. With oocytes, we know the total number of oocytes at the time of retrieval, as well as the number of mature oocytes that are available. But with embryos, we have more information, which we can use to help plan pregnancies for the patient, related to the grading of the embryos or the genetic makeup of the embryos. For patients that are deciding between which option, both options are eligible for grants, such as Livestrong funding, Team Maggie, or Walgreens, that can help provide financial assistance for the medication coverage. Both of these procedures will also require the same 10 to 14-day controlled ovarian hyperstimulation process, and they require the patient to be postpubertal in order to undergo the gonadotropin stimulation. And at the bottom, you'll see the live birth rates, which are mostly driven by age of the patient. We've touched on this already, but this graphic just shows how biopsies can be taken to test for aneuploidy, PGTA, and also PGTM for monogenic disorders. A laser is typically used to create an opening in the side of the embryo at the site of the trophectoderm, the cells that will not make the inner cell mass. And those cells are then taken off with this biopsy pipelle and sent off for genetic testing. This is a statement from ASRM. It talks about how PGTM can be used to identify embryos that do and do not carry hereditary cancer mutations. And this paragraph was mentioned in the previous talk as well. But there may be some challenges that exist to allowing patients to undergo PGTM, including financial barriers. Many times there's no insurance coverage to pay for this type of treatment, and it can be very expensive out of pocket. But it can allow for it's efficient in allowing for embryo selection, but only if we have enough embryos available. And many times with PGTA and PGTM testing, we may eliminate all embryos prior to the transfer. Barriers that we discussed include limited awareness of PGTM amongst oncology providers as far as the procedure, the cost, and the timeline that may be required in order to pursue these treatments prior to therapy initiation. The financial barriers, so there may be an out-of-pocket cost of around $5,000 or more for medications. the procedural costs, which could be $10,000 to $20,000, and then the genetic testing procedural cost as well. There's also psychological distress for the carriers that are undergoing all of this testing. If a patient is to become pregnant and then have the psychological distress of considering terminating a pregnancy, if they spontaneously conceive, there's also PGTM can also be, tested in different populations, and so there may be some concerns regarding non-oncologic use of PGTM that may be psychologically challenging for patients. Another option for fertility preservation is ovarian tissue cryopreservation. This method has been used worldwide and is now becoming more available in the United States as well. So far, there have been over 200 live births, 2 from premenarchal patients, the rest from post-pubertal women. The selection criteria to help choose correct patients would be women under the age of 35 with a robust ovarian reserve and their prognosis at 5 years. Some contraindications include ovarian involvement of their tumor and pelvic radiation, which may deplete their ovarian reserve. The cumulative clinical live pregnancy rate is 30% with a live birth rate of 25 to 30%, and that again depends upon the patient's age and also the method that was chosen to achieve their pregnancy, with natural pregnancies being more common than IVF. Their patients will also experience an endocrine restoration after reimplantation of the ovarian tissue of up to 70%. So they may resume menses, they may have improvement of hot flushes, night sweats, menopausal type symptoms after the tissue is reimplanted, but that is short-lived. It typically will occur within the first few months and only last a few years after implantation. These pictures just show how ovarian tissue is obtained. It can be done laparoscopically at the same time as another procedure that the patient may be undergoing for their treatment, such as a port placement or other diagnostic laparoscopy. A portion of the ovarian cortex is stripped off and then brought back to the lab where it's cryopreserved in segments. Some pitfalls of this treatment include significant follicle loss that occurs due to ischemia after transplantation, and that can limit the lifespan of the graft. So 80% of the ovarian follicles that are present at the time of cryopreservation may be lost during the transplant thawing process. There may be some potential benefit in the future of adding angiogenic or anti-apoptotic factors that may help prolong this longevity of the tissue. And other risks involved with this procedure include potential reintroduction of occult tumor cells that could be present at the time of transplantation. So it's important to have thorough histological examination prior to retransplant. It's also common to have higher risk cancer types that involve the ovarian cortex, such as ovarian cancer, obviously, but also lymphomas that may have metastatic disease to the ovaries. So it's important to counsel those patients accordingly prior to proceeding with this procedure. And in vitro maturation will hold future promise to help us avoid the risk of reimplanting occult tumor cells at the time of retransplantation. Finally, we'll talk about ovarian suppression with GnRH analogs. So this option may be covered for some patients by insurance under the premise of menstrual suppression, and it has been studied in breast cancer patients to show some reduction in treatment-related premature ovarian insufficiency. The mechanism of action, so their GnRH agonists will serve as a potent inhibitor of GnRH secretion with chronic use, and this therapy is not considered useful in prepubescent children because they're not having that GnRH cyclings already prior to the administration of the treatment. It's thought to be useful in women that are post-pubertal or other patients that are going through pubertal transition, and it's thought to be related to the chronic use of the medication. The proven benefits remain to be shown, but some studies have shown pregnancy occurred more commonly in women that had GnRH analogs in comparison to those that had chemotherapy alone, with 21% versus 11%, and also a decreased rate of premature ovarian insufficiency in women that were treated with GnRH analogs. However, there was also a large meta-analysis that did not find any difference in ovarian function. Typically in our population, if patients are not able to undergo oocyte or embryo cryopreservation, then we'll offer them a GnRH analog as it may be covered by their insurance and it may provide some menstrual suppression during their treatment. But it's important to counsel patients that this is not a proven therapy for fertility preservation, it may potentially have benefit. And then ovarian transposition can be done before treatment with one or both of the ovaries and or the fallopian tubes. They can be separated from the uterus and brought above the pelvic brim to lower the amount of radiation exposure. Some patients can have resumption of menses, although it varies significantly, and that's probably related to damage to the vascular supply to the ovaries as well as some scatter radiation. Spontaneous pregnancy is unlikely with this option, and if a patient desires undergoing oocyte cryopreservation, they may need repositioning of the ovaries after the radiation is completed. There's also alternative options for family building that should be discussed with all patients, including adoption, the use of donor gametes or donor embryos, and surrogacy. It's important that we mention the psychological impact that cancer diagnosis may have in a young patient during their reproductive years. There's several options available for counseling and pamphlets, information that we could provide to patients on these resources to support them during their time of diagnosis. Thank you.